Welcome to the 6th webinar in our Transition to Transplant series. Today we have Dr. Kien from St. Michael's Hospital in Toronto with us to speak about mental health in patients with cystic fibrosis undergoing a lung transplant. At the end of the talk, there will be an opportunity to ask questions via phone or via the chat feature on the right-hand panel of the screen. Kien, thank you for joining us today, and I'll pass it over to you to start today's talk.
Thank you so much, Joanna. It's my pleasure to be here. As Joanna said, my name is Kien. I'm a psychiatrist at St. Michael's Hospital, and I am integrated into the cystic fibrosis team. I see patients there on a regular basis, and I've also done some work with the transplant team in my residency program way back in the past. So I wanted to sort of chat a little bit today about various stresses, psychosocial stresses, as well as mental health challenges that can present prior to transplant, but also during the transition to transplant, and also really wanted to think about what you as healthcare professionals could do to identify these issues, as well as potentially proactively start treatment of these issues if you feel comfortable, and the reasons why for that. So first off, I do need to tell you that I have absolutely no financial disclosures to make. I do not have any financial relationships with any pharmaceutical company or any other industry at all. So I make this disclosure because I will be talking about some medications. So the objectives today, I'd like to start with maybe talking about some of the stresses that patients with CF may experience while transitioning to lung transplantation. I want you to think about why we want to identify and treat depression and anxiety early on in the transplant process, or even prior to the transplant process as well. And then I want you to, whoops, how this went back. There we go. And I also want to discuss treatment options for depression and anxiety disorders throughout pre-transplant, but also throughout the transplant process, and the pros and cons of each, as well as the feasibility of each of the options, and what you and your centers can do as well. So I'm sure all of you have had experiences with patients with cystic fibrosis whose lung function may be deteriorating to the point of needing transplantation. And think about what the experiences might be like for these people. Now, as lung function deteriorates, people who were potentially extremely high functioning before with regards to social life, physical activity, occupation, school, become more limited. And because of those physical limitations, you can see in patients as a result of that, not be able to work anymore, not be able to engage in as many social activities because of the fatigue that's of their illness. And basically, these are often coping mechanisms that we all use to keep ourselves well. There is the structure of work, of school, of family, of engaging. There's a certain normalcy surrounding all of that, and a certain routine that people get into. And when physical limitations affect that, that there is a possibility of the emergence of more stress, as well as the emergence of depression and anxiety disorders. As well, mortality is something that I think a lot of CF patients think about over the course of their life, knowing that CF is a life-threatening illness. But those thoughts can become more significant as lung function continues to decline, and as transplant becomes discussed a little bit more. So, over the course of the transplant process, there is also this uncertainty of meeting the various criteria for listing for transplant, whether it be medical or psychosocial criteria. So it's almost like through the transplant assessment, there is this intervention that can be potentially life-saving that is not necessarily automatically given to every single patient. So there is that uncertainty that can cause a lot of stress. And then once listed, there is that uncertainty of organ availability. Will I get the transplant, or will my lungs deteriorate too much in the interim? So all of that uncertainty creates an additional amount of stress for patients. And lastly, also, transplant centers are few and far between across Canada. And in order to, once listed, if you are living in a more rural center or a place that is not near a transplant center, there is relocation that's required because lungs can come in at any time and you need to be close to the transplant center in order to have that potentially life-saving surgery very, very quickly without very much warning. So relocation to a transplant center can be very, very stressful as well. First of all, from a financial perspective, which is significant. I know the cost of living in Toronto, where I'm from, is extremely high. So relocating to Toronto, as an example, is extremely expensive. And you have to adapt to a new living environment, potentially to a much different culture, a much bigger city, much busier place that people may not be used to, and also even the idea of adapting to a smaller living environment. And being far from family and social supports, yes, a social support person often relocates as well, but you're still far away from the vast majority of people who are familiar with you and who are good supports, whether it be family or friends. So all of those increase the stress levels tremendously for patients potentially. I think another theme that you can think about with chronic illness and the transplant process is the theme of losing control. You have a life plan or a life routine, and all of a sudden you get blindsided by health deteriorating, whether it be slowly or quickly. There is this feeling of losing control or being at the mercy of having to do things that were not necessarily in your choice to do so. So all of these stresses can increase the risk or severity of mental health disorders. So whether it be depression, anxiety disorders, substance use disorders, or premorbid personality-related issues, and someone's coping style, all of these can be exacerbated by all of the various stresses that somebody can experience. So, which is why we really want to think about how to optimize mental health. With regards to transplant, you only really have one good shot at it. Yes, there are people who've had repeated transplants, but you really want to be in as tip-top shape physically as well as mentally in order to go through all of the various stresses that come with the transplant process. So you want to be on your A game. There are a lot of demands with regards to relocation, with regards to transplant appointments, with regards to compliance with treatment recommendations, physiotherapy, blood work, et cetera, and this happens both pre-transplant and there are also demands and changes post-transplant. So you want to be mentally on your A game for that. Also, there may be an association with higher self-report depression scores and high distress being associated with a mortality post-transplant. There's a study that was published relatively recently about this in 2016. So there may be some implications with outcomes post-transplant as well. Again, reasons why we want to optimize mental health as much as possible. Other reasons is that unstable mental illness itself may affect appropriateness for transplant listing, and this may include a variety of disorders, including depression, psychotic disorders, bipolar disorders, and substance use disorders. And the reason for this is if you have any mental health disorder that can affect your ability, your motivation, your desire to have a transplant, and your motivation to be able to comply with all the various treatment recommendations, then that will be associated with a poor outcome post-lung transplant as well. So, which all the more reason why you want mental illness to be as stable as possible prior to transplant listing. In addition, with regards to substance use disorders, we know that smoking anything will be a contraindication to a lung transplant, actively smoking anything will be a contraindication to lung transplant. And then opioid use disorders for pain can be significant as well, whether it be something that's actually been created iatrogenically or not. patients who develop a significant tolerance to opioids will have challenges in their recovery from a pretty major surgery that requires opioids in the postoperative period. Other reasons to get on this early is because treatment of mental illness and the development of new coping skills takes time. It's not something that can happen overnight. Even with pharmacotherapy medications for mental illness, it doesn't happen quickly, and there is a certain amount of patience that's required in treating mental illness. Being listed for transplant or having relocated and then having treatment start, you're sort of sometimes racing against the clock with regards to when a transplant may happen. So good to get on this early. So there's this consensus statement that was published in Thorax in 2016. Alessandra Quittner is a psychologist who has done a lot of work with regards to mental health and cystic fibrosis over the years, including the TIDE study regarding epidemiology around mental health-related issues in cystic fibrosis. So I came up with this consensus statements for screening and treating depression and anxiety, specifically in patients with cystic fibrosis. I think it's really, if you haven't seen it, it's worth a read because we know that mental health issues and chronic illness in cystic fibrosis are prevalent, and sometimes access to mental health resources is limited, even in the larger centers. So I'm going to go through some of the aspects of this consensus statement around depression and anxiety. So first of all, just a review of what the DSM criteria are for major depression and generalized anxiety. So the person with major depression, of course there's variable severities with regards to major depression. The person with major depression is a person who is consistently depressed on an ongoing basis. Somebody who's either depressed or, if they can't identify being depressed, because there are people who are not good at identifying the emotions that their emotional experience. The idea of diminished interest or pleasure, lack of joy in a lot of activities. So there's this consistency of these symptoms over the course of a number of weeks, at least 2 weeks according to the DSM, although often you see it chronically a lot longer. In addition to that, symptoms include change in appetite with regards to weight loss and weight gain, changes in sleep, psychomotor changes, which may be this sort of edginess or agitation and anxiety, or overall slowing, fatigue, feelings of worthlessness or excessive guilt that are, again, consistent on an ongoing basis, decreased concentration, recurrent thoughts of death, which is different than thoughts of suicide. That both are possible in somebody with major depression. What's tricky about a lot of these symptoms is some of these symptoms overlap with symptoms of chronic illness. The neurovegetative symptoms are a little bit tricky, especially if you're sick and you have insomnia as a result or fatigue as a result of that. So a lot of the cognitive symptoms are something that you may want to look for in particular. With regards to generalized anxiety disorder, a lot of people are untreated for a generalized anxiety disorder and live with this disorder on an ongoing basis. These are the people who tend to be the worrywarts, people who worry on an ongoing basis. So the criteria includes excessive anxiety or worry, at least 6 months over a number of events or activities. So it could be ongoing worry about health, worry about safety, worry about family members, worry about money, worry about the people who often think, what if, who are all often in their head about various essentially relevant or less relevant worries. And they often don't notice that there's anything seriously wrong because they function fine. They just have anxiety on an ongoing basis. That may not be the most pleasant symptom. The challenge with these patients, these people, is that they have a lot of difficulty controlling the worry, and they may also have other symptoms associated with it, which include feeling on edge, easily fatigued, having challenges with memory or concentration, or having their mind go blank, maybe a little bit more irritable and a little bit more tense, and also have difficulties with sleep, often because they're thinking about all of the worries that are going on. And as I said, people are often very functional with these constellations of symptoms. Add the stress of transplant, and these symptoms could significantly increase. So I have seen patients who have been untreated from a generalized anxiety perspective, and their anxiety skyrockets in the context of worsening medical illness, worsening CF symptoms being listed for transplant. So just keeping that in mind, I'm sure you may be able to think of some patients that may fit some of those criteria. The idea is early identification. And the only way to identify it is to ask. The consensus guidelines do recommend annual screening. They recommend annual screening. It doesn't mean that you can't screen more often than that. It's like, you have annual blood work as investigations, but it doesn't mean you're not going to order blood work in the interim. So annual screening for depression and anxiety is something that is recommended for all patients, and then there are self-report questionnaires that they recommend, including the PHQ-9, which is very, very strongly associated with the DSM criteria for major depression, as well as the GAD-7. Both of them are free to use and widely available and validated as well. The tricky thing is that these are general self-report questionnaires for people, screening for people for depression and anxiety, not specific for patients who have comorbid medical illnesses. So keep in mind that these are screening tools, and that neurovegetative symptoms do overlap with chronic illness as well. So you may have people screening more positive. However, having said that, I would rather people have a more false positive, so that people are more healthcare professionals are thinking about it and reflecting on whether or not patients do need interventions from a mental health perspective, as opposed to missing out and not identifying in the first place. So if you're not doing this already, it's something to think about implementing. One of the challenges that I know we experienced in our clinic when we implemented annual screening for depression and anxiety was a little bit of a discomfort around questions and what to do if somebody screens positively for suicidal ideation. As I get further away from medical school, suicidal ideation is something that I screen for on a regular basis. It's old hat. My colleagues in respirology do not have the same level of experience and the same comfort level, so there was some education that was required about what to do if somebody screens positively for suicidal ideation, and also what to do in case the suicidal ideation is quite active. There's a plan and intent, what the protocol is for emergencies as well. So hopefully that you have people in your team who would be comfortable assessing for psychiatric emergencies, or somebody who's accessible to help you out if there is a suicide risk that you are concerned about. Again, better to ask than to have it quiet. So when it comes to treatment, I wanted to think about whether or not you can actually implement treatment for patients you identify. Psychiatric support is variable, and we know in general that there is a shortage of mental health supports and psychiatrists across Canada. So all the more reason that sometimes if there's things that you can be, treatments that you can be comfortable with initiating, that would be very, very helpful, especially if there is a significant wait time to get a psychiatric consultation. So antidepressants are the mainstay for treatment for depression, as well as anxiety disorders. They're called antidepressants, but they are the mainstay for treatment for anxiety disorders. The issue with antidepressants is that they do take at least 4 to 6 weeks to have an effect, and of course you've got to get to a therapeutic doses for that patient, which can be variable. We cannot predict which patients will respond to which medications and which patients will respond at all. So there is a bit of a trial and error, which can, as a result, delay full effect of any kind of treatment. So ideally, 4 to 6 weeks for effect. Often you have to do multiple trials to see whether or not there is any effect of medications. Antidepressants are non-addictive. You don't get any hit from them because it takes 4 to 6 weeks to have an effect. You're not going to feel a high. You're not going to crave antidepressants. Other advantages of antidepressants is that they are available, they are convenient, requires minimal effort from a patient perspective. And again, I should also say that they are very safe. Side effects of antidepressants. That's probably the disadvantage of medications, that all medications have potential side effects. Most side effects of antidepressants do tend to go away after a week or two of initiation of the antidepressant, and those are often gastrointestinal disturbance, sleep disturbance, increased anxiety for a little bit before anxiety gets better, headache. In adolescents and young adults, there has been a warning about potential increase in suicidal thinking. I don't want this to spook anybody at all because in the studies, although there was an increase in suicidal thinking, there was no increase in actual completed suicides. So it's something that, yes, does require a little bit of monitoring in adolescents and young adults, or especially in the context of depression, but should not prevent treatment of depression. If anything, you wonder whether or not people being less likely to prescribe antidepressants actually increases the overall suicide rate because there's untreated depression that's out there. Side effects that are generally more persistent include sexual dysfunction, which is what patients complain to me about the most, which can include decreased libido or anorgasmia, vivid dreams, and also inhibition of platelet aggregation. I'm just going to take you through a few antidepressants, and the antidepressants that are mentioned in particular in the consensus statement are escitalopram, citalopram, sertraline, and fluoxetine. So I'll take you through those because the reasons why they suggested these antidepressants in particular is because they are first-line treatments for depression and anxiety disorders. They are available, they're not costly, and generally less complicated with regards to drug-drug interactions, which I'll get into a little bit. So first medication, escitalopram. The starting dose is often 10 milligrams. In patients who are anxious, they may be more hyper-aware of side effects, so I will often start people at 5 milligrams even and titrate that up to 10 milligrams after about a week. If there is minimal effect at 10 milligrams, then you can increase it to 15 and titrate up to a maximum of 20 milligrams daily. The good thing about escitalopram is that there are very, very few drug-drug interactions. It is a very mild inhibitor of the cytochrome P450 system, so very, very minimal drug interactions. Well-tolerated. It's a good medication overall. Also does have some good evidence, some reasonable evidence in adolescents in particular. My child psychiatry colleagues actually would put this as their number 2 when it comes to prescribing antidepressants in adolescents. The issue with escitalopram is that it is more associated with prolongation of the QT interval on the electrocardiogram, and we know that a lot of our CF patients may be on other QT prolonging agents, including the various antibiotics. The other two medications, two other medications mentioned in the consensus guidelines include sertraline and fluoxetine. Sertraline, starting in dose at 25 milligrams, can be titrated up to a maximum dose of 200 milligrams to effect. I've seen effect at 50, 75, 100 milligrams easily. It is a moderate 2D6 inhibitor, but still pretty good when it comes to drug-drug interactions. Not something that I really worry about, and it's a fantastic medication. Fluoxetine is the other medication that is mentioned in the consensus guidelines. The dosing is between 20 and 60 milligrams daily. It's available in liquid form as well, and it is the #1 medication to be used in adolescents in general. It does have, of all the antidepressants, has the strongest evidence for depression in adolescents. The reason why you may want to shy away from fluoxetine is it does have potent it does have potent inhibition of 2D6, so be aware of the potential drug-drug interactions with fluoxetine. It does have a pretty long half-life, which actually is good for people who have issues with compliance because you can reach a steady state, you can maintain a steady state even if you miss the doses here and there. I'm going to mention one other medication as well that's not mentioned in the consensus guidelines, the medication that I use quite often in the cystic fibrosis population. It's mirtazapine, and the dosing is generally between 15 and 60 milligrams daily. It also has minimal drug interactions. It's actually milder when it comes to sexual side effects as well as gastrointestinal side effects. One of the reasons why it may not be included is because there's less evidence for anxiety disorders compared to the other antidepressants. Having said that, I have plenty of patients who are on mirtazapine who have found it extremely helpful for their generalized anxiety disorder. And it is a recommended treatment for anxiety disorders, just not first line. The reason why I often prescribe mirtazapine is because of the side effect profile. The side effects include sedation, but more significantly, weight gain. It is notorious for increasing appetite and increasing weight in the general population, which is why many people shy away from agreeing to be on mirtazapine. In our population, especially as they're getting sicker and going towards transplant, where weight is so important, at least maintenance of weight, the mirtazapine is often a preferred medication by patients because it can potentially treat depression as well as stimulate weight gain. I know our dietitians at our clinic in Toronto have a little bit of, they're kind of happy when I prescribe this medication in particular. Other things to know about antidepressants, there is a contraindication with linezolid, there's risk of serotonin syndrome, and also another interaction that's important to be aware of is with lumacaftor, which induces the metabolism of escitalopram, sertraline, and mirtazapine, so you may require higher doses of each of those three to have the same effect if somebody's on lumacaftor. So think about this. It's, if you're trying to get a psychiatric consultation, and depending on where you're at, if it takes a month, it takes 2 months, 3 months, that's a significant wait time. If you feel comfortable initiating an antidepressant early on, it is very, very low risk, and you may be able to get more of an effect earlier on, especially when you don't have the luxury of time to wait. So with regards to non-pharmacologic management, there are a lot of evidence-based therapies that can help with depression and anxiety. The advantage of these non-pharmacologic strategies is that they don't have any physical side effects. However, all non-pharmacologic interventions require time, commitment, motivation, and effort. And when you are sick or thinking about transplant, the scheduling may be a challenge because your mind may be elsewhere, your priorities may be elsewhere as well. So cognitive behavioral therapy is a mainstay of treatment for depression as well as anxiety disorders, and it's extremely effective. What it does is it retrains somebody to think a little bit differently. So often with depression and anxiety, the thoughts that people have are quite negative or a little bit more on the extreme side. Thoughts like I'm worthless, I'm going to die. The very, very absolute thoughts, or this will never happen. I will never have a transplant. Something bad is going to happen. Like those kinds of more extreme thoughts that are not completely evidence-based. And what cognitive behavioral therapy strives to do is have people identify and analyze those thoughts in a way and break it down to small chunks and analyze the evidence for and against that thought so that they can come up with more balanced thoughts. it's a training program. The analogy I often give is if somebody has poor technique with regards to playing a musical instrument or any sort of physical activity, any sort of sport, in order to repair those challenges, you have to break down the technique into small chunks and practice all over again. And that's the same with cognitive behavioral therapy. You need to identify those thoughts, analyze those thoughts, and practice coming up with those more balanced thoughts. Requires time and commitment. Yes, you can do it on your own, but like any other skill, it's more effective if you have a coach, also known as a therapist. So, weekly appointments for 1 hour plus homework, very effective. However, whether it's feasible or not is another story. Interpersonal therapy is another evidence-based therapy for mild to moderate depression. Again, there's homework involved as well as weekly 1 hour appointments for 12 to 16 weeks, similar to cognitive behavioral therapy. Mindfulness-based cognitive therapy, mindfulness-based stress reduction is something that I think is fantastic. A lot of the principles around mindfulness is using meditative practices to become more aware of the present moment in a non-judgmental, self-compassionate way. Again, it's a skill that requires commitment, practice. In a formal setting, you probably can get more out of it. Doesn't mean that patients shouldn't try on their own. There is also evidence for exercise, regular aerobic or resistance training that can be helpful for mild depression. But again, there are physical limitations that can happen that can limit ability to pursue exercise. So again, these are all fantastic interventions. However, whether or not they are feasible, what the availability is in your centers as well to get any of these therapies, the wait times and as well the cost. There are psychiatrists and family doctors who do cognitive behavioral therapy as well as other modalities, but there may be significant wait times for that. Otherwise, you're paying out of pocket. There's limited coverage from private plans for psychologists and social workers. So here are a couple of things that you could recommend for patients if they wanted to try things on their own. These are just a couple of workbooks that I often recommend. Mind Over Mood is a cognitive behavioral therapy workbook. The Mindful Way workbook is a mindfulness-based cognitive therapy workbook that also includes a CD of various tracks. I know there are a lot of apps that are available. I know Headspace is a mindfulness app that people have been using. And even the idea of coloring books. All the rage nowadays are those adult coloring books with intricate designs. Coloring itself is a very, very mindful activity where you have to be in the present moment, focusing on the task at hand. So all of these various things are available for patients. Again, it requires time and commitment to be able to develop new coping skills, new coping strategies. The earlier you can get on it, the better. So, just in summary, a few take-home messages. You know, we all know that the transition to transplantation, to lung transplant, is very, very stressful, and all the various factors that are involved with that, with transplantation. I want you to think about how to intervene early with regards to stress as well as mental illness. Even the idea of developing new coping mechanisms, and whether it be through mindfulness, whether it be through CBT, it does take time and practice to be able to do that. There is a recommendation for annual screening for depression and anxiety. It doesn't mean you can't screen more often if it's clinically indicated, but in order to treat depression and anxiety, we need to be able to identify it first and identify it early. Medication treatment. Antidepressant therapy is safe, effective, low risk, but still does take time to have full effect. We're still looking at potentially 4 to 6 weeks minimum for an effect of an antidepressant and potentially other trials. This is something that if you feel comfortable starting on your own, you would be able to get the jump, a little bit of a head start on treatment of depression and anxiety while they wait for potentially a psychiatric consultation. There was one other thing I wanted to say about antidepressants. Oh yeah, the idea, because antidepressants are generally safe and effective, people worry about having unnecessary treatments. Having said that, in the context of something high stakes like lung transplant, rather overshoot the risk, or that's the wording I'm trying to say. Rather be on the safe side to optimize mental health as much as possible, in my mind, as opposed to having the risk of untreated mental illness or excessive anxiety or depression that may affect their ability to meet all the various needs of transplant. The evidence-based psychotherapies can be performed by social workers, psychologists, family doctors, psychiatrists as well, but they do require significant commitment from patients, and also the availability is tricky in general. If there are psychologists that are available and patients can afford it through their private health plans or through their own out-of-pocket, it's fantastic. Again, there's still that commitment that's required. You can't get results. You can't get to the Olympics without a time commitment. You can't develop new coping skills. You can't treat depression and anxiety from a non-medication perspective, from a training perspective, without the commitment and motivation as well. So I hope you guys can think about what changes you might be able to make with regards to your usual practices, or maybe this consolidates the practices that you already have. These are some references as well. I think that consensus statement from Thorax that's published in Thorax by Alexandra Quittner and all is probably a very important read. There are other guidelines from the psychiatric world. The Canadian Canadian Network for Mood and Anxiety Treatments, CANMAT guidelines, are published in 2006 with regards to treatments of depression. There are also anxiety disorders guidelines as well. I don't think that's necessarily important for you to be as aware of, but just to know where the treatment guidelines do lie. Thank you so much. If you have any questions, I'm happy to answer them at this point.
Thank you, Kien. We are now open for questions. You can use the raise the hand feature, and I can unmute you if you'd like over the phone, or you can type your question into the chat box, which is on the right-hand side of the screen as well.
I'm not the best with this technology, but
I'm not seeing any questions, so we can conclude the webinar here. The webinar has been recorded and will be posted up on the healthcare section of Cystic Fibrosis Canada's website under the Transition to Transplant tab, and the recording should be available next week. You can also see all of our upcoming webinars on our website, and registration will be emailed as future webinars are scheduled. Thank you again, Kien, and to everyone that attended today's session. Bye.
Thank you.